Hey everyone, welcome back to part 3 of our ED Facility Coding Explainer. If you've been with us for the first 2 parts, you already know the golden rule. Facility coding is a totally different beast than professional coding. It's all about the actual time, effort, and resources your hospital staff spends on a patient. Today, we're putting those rules to the test. We're going to break down the exact definitions of discharge instruction complexity and then apply them to 2 real-world emergency department cases.
Here is the game plan for today. We'll start with the 4 discharge instruction tiers. Then, we'll dive right into our 2 case studies, one for pelvic pain and another for dysuria. Finally, we'll wrap up with a huge takeaway on how facility code leveling is strictly driven by staff interventions.
All right, let's jump right into Section 1, Discharge Instruction Complexity. When a patient leaves the ED, the nurse doesn't just wave goodbye, right? They have to make sure the patient knows exactly what to do next. But obviously, not all instructions take the same amount of time. The guidelines break this down into 4 specific steps. Think of it on a sliding scale. On the low end, it's like giving someone basic street directions. On the high end, it's like coaching them through a highly technical repair manual. Let's see what actually separates these 4 levels. Starting at the bottom, we've got straightforward and simple instructions. Straightforward means the patient has a self-limited condition. Think a minor scrape or a mild sunburn. No home medications are needed. The nurse just gives a quick rundown of infection signs and says, "Come back if things get worse." Simple is just one step up from that. Here, the nurse might suggest over-the-counter meds, like taking some ibuprofen, or teach a really basic dressing change. The big takeaway for both of these, the patient gets it immediately. It's quick, it's easy, and it barely takes any of the nurse's time.
Now, let's turn up the dial to moderate and complex. This is where staff effort really starts to climb. Moderate instructions involve teaching a brand new skill, like how to safely use crutches or going over weight-bearing limits. It also includes reviewing a single new prescription medication and its side effects. The patient might ask a question or two, but they catch on fine. Complex instructions, though, that requires heavy lifting from the nursing staff. We're talking about reviewing multiple prescriptions or home therapies. Think intense education, like diabetic teaching, seizure management, or asthma protocols. Most importantly, this level applies when a patient or their caregiver is having a really hard time understanding the instructions, and the nurse has to spend extensive time making absolutely sure they are safe to go home.
Okay, moving on to Section 2. Let's test this knowledge on our first case study featuring a high-level E&M scenario.
So, we have a 48-year-old female presenting to the ED complaining of pelvic pain. What really makes this case interesting is her medical history. She has a history of an MI, a heart attack, and AFib. Because of that cardiac history, the clinical team has to be way more careful with her. And guess what? That directly translates into a lot more facility effort.
Let's look at exactly what the nursing and ancillary staff actually did. Remember, we are not looking at the doctor's medical decision-making here. We are solely counting the staff's physical work. They did an initial assessment and ran bedside labs, a stool hemocult and a urine dipstick. The nurse inserted a saline lock IV and drew blood. They also placed a Foley catheter to get a clean urine specimen. When the ED doc came in for the pelvic exam, the nurse stayed in the room as a chaperone. Then she needed a pelvic ultrasound. But because of her heart history, they couldn't just throw her in a wheelchair and send her to radiology alone. They had to transport her while maintaining a continuous cardiac monitor. Finally, when she was diagnosed with a ruptured ovarian cyst, the nurse provided complex discharge instructions.
So, how do we code this? The golden rule of facility coding is that you look at all the interventions and find the ones that map to the highest possible level. You do not average them out. Checking the guidelines for this case, 2 massive staff effort indicators jump out: the cardiac monitoring during transport and those complex discharge instructions. The guidelines explicitly list frequent monitoring of cardiac rhythm and complex discharge teaching as top-tier interventions.
Because those specific, high-effort actions map exactly to the top, this case lands perfectly at a level 5, or CPT 99285. It honestly doesn't matter that the urine dipstick is a low-level task. The fact that the staff had to monitor her heart during transport and give complex discharge teaching pulls the entire visit straight up to a level 5.
Let's switch gears. Section 3, our second case study. This one is a moderate-level scenario for dysuria.
Here we have a 66-year-old female who is usually in excellent health and takes no regular meds. She comes into the ED complaining of a low-grade fever, dysuria, which is pain when urinating, and urinary frequency. Let's track the staff's footprint on this visit. The nurse does an initial assessment. The doctor orders a clean urine specimen, so the nurse performs an in-and-out Foley catheterization. They do a bedside urine dipstick test, and yep, it's positive for an infection. The physician diagnoses a standard UTI. Now, here is a major intervention to watch for.
The nurse actually administers oral prescription medications right there in the ED. They give her 1 tablet of pyridium for the pain and 1 tablet of Bactrim, an antibiotic. To wrap up, the nurse provides moderate complexity discharge instructions before sending her home.
If we pull up the Level 3 guideline matrix from our source, we see our exact interventions explicitly listed. Look right there. Prescription medications administered PO. That covers the pyridium and Bactrim. Right below it, Foley catheters, in and out CADs, exactly what the nurse did. And down near the bottom, discussion of discharge instructions, moderate complexity.
Because the highest interventions match exactly to level 3, the final coding decision is a total breeze. We always check the level 4 and level 5 columns just to be absolutely sure, but there were no IV meds given, no heavy monitoring, and no complex discharge instructions.
So we lock in the final code at CPT 99283. This perfectly proves that facility coding is all about matching actual staff effort to the guideline tiers. It's literally a point system based entirely on what the clinical staff physically did for the patient while they were in the building.
All right, that brings us to Section 4, the final takeaway. Always code for effort.
The difference between a Level 3 and a Level 5 facility code often comes down to the fine details of nursing care that can easily get lost if we aren't paying close attention. Always remember, facility coding measures your staff's physical work, not the final diagnosis. In our first case, a ruptured ovarian cyst could easily be undercoded if you miss the cardiac monitoring during transport or the complex discharge teaching. So ask yourself, are your clinical notes capturing every drop of effort? Because if it's not documented, you cannot code it. Make sure your team gets the credit they deserve for the hard work they do. That's a wrap for Part 3. We'll see you in the next explainer where we tackle the rules for critical care.